Good evening, everyone, and welcome to tonight's meeting of the Health and Wellbeing Board Community Subgroup. I think tonight's meeting builds on some of our most recent meetings, including the workshops on how we best work together to communicate and engage around COVID-19, particularly around achieving vaccine equity. And that's really the focus of this evening's meeting. But I'm really glad to welcome both Hannah from BAME Voice and Andy from Merton this evening, who will be presenting some of their findings and recommendations around engagement and communication with both Black and minority ethnic groups, as well as those with a learning disability and or autism. So in terms of the sort of structure of tonight's meeting, I think we'll first hear from Dagmar, who'll present an update on the sort of COVID situation, and then we'll follow on with those presentations and also a presentation from Barry before we move into sort of a broader discussion and debate on some of that engagement and communications that we would have heard. But just to kick off, just under apologies for absence, I think we've had apologies given from Rob, Phil and Martin. I think that might be everyone. Clarissa, great, that looks like everyone. Oh, Mark.
Just apologies, that I need to leave at 6 o'clock. Unfortunately, I've got another meeting that I can't change, so apologies for that.
Great, thanks, Mark. And then we move on to declarations of pecuniary interest. Are there any? Okay, I can't see any there. And then minutes of the previous meeting. So this was the meeting on the 12th of January. Can I just check that those are an accurate record? Anyone dissenting or any questions on that? Great. That looks all good. Okay, so in terms of sort of the first main agenda item, I will pass over to Dagmar to provide the COVID update.
Hi, good evening or good afternoon. It's still light. I don't know whether anybody is helping me with the slides. I think if you can do, otherwise I talk you through. So just to let you know, I think I want to make this pretty speedy because I'm really delighted that we have got the presentations around the inside, and that's the focus of this meeting. If you move me on to the summary. Super. So good news, our infection rate has dropped again a bit. You can see there, it's now less than 20 per 100,000 over a week. So that looks very good for Merton. Now, you will have heard, though, that there is a bit of anxiety in the system. So in a later slide, you will see it's a bit checkered in London now, while the average is still around 20. There are some outliers, so some are less, and then Hounslow as the borough with the highest infection rate, nearly 60. So that gives you the relative overview, and then if you go, I leave those slides as the real reference for you, but I wanted to go onto the Vox slide, this one. So variants of concern, and this is a first attempt to capture some information on a slide. It is a very imperfect slide, and you will see that we're lagging behind. We are trying to align all the different data flows, but just as a quick reminder, variants of concern, you probably have heard in the news, the virus mutates all the time. We are interested and concerned about those that are more transmissible, that can escape either in the natural immunity or vaccine immunity, and possibly those that show more serious disease. The one at the moment that captures our imagination particularly is the so-called Indian variant. This slide helps you to understand all the different variant names, common names. It is quite a confusing business. I haven't listed all, but I've listed those that you will hear being talked about. And the lowest is at the lowest row is the Indian variant. You will see that London has substantial numbers now. In Merton, identified, I've only got one so far. But what is now coming to light is that the actual genomic sequencing is lagging behind quite a bit. And there is a cleverer method, or a quicker method, that shows us very quickly whether we have got the Kent variant or not. And what we are now assuming is anything that is not the Kent variant is by sort of assumption, and possibly the Indian variant. And so what has happened in London, we used to be nearly 100% Kent. And over the recent weeks, that has dropped. And so in some of the boroughs, particularly in the northwest, there is now a gap. So the Kent variant is now only about 60% or even 50%. So assumptions are, but even in Merton, although I have only one at the moment positively identified, that there are probably more. Yeah, and so the assumption will be that it could well be that the Indian variant is replacing the Kent variant because it appears more transmissible. You will have obviously, not obviously, but hopefully heard in the news the good or the encouraging news over the weekend around vaccination response. And it looks encouraging that both the AstraZeneca and the Pfizer vaccine are effective for the Indian variant, but it is important to stress that the full effectiveness really is only with the second dose. So that is an important message for all of us when we're out there, to now push that people not only have their first, but both doses. You will have heard, and just so that you know, good news again, you saw it in the summary, so our over 60s rates are really low now, below 10, and obviously these are the most high risk illnesses, and so that is an absolute success. That is mirrored in that the hospitals haven't got lots of admissions, but where we've got now outbreaks is mainly in schools. And that is not surprising, because obviously that's where the unvaccinated are. And so again, we're working very closely with Public Health England and the Department of Health and Social Care in London to manage, and the DfE to manage the various school outbreaks. So again, a number of you will be parents, really important, the testing. You know, one can tire a bit with the testing, and I'm sure you've got the packets of 7 tests in a packet on your windowsills and kitchen tables. Really, really important, particularly with the school outbreaks and the really transmissible variant. So that gives you just a little bit of a flair. So that is what that space amongst generally good news. If you move us on, and if I just give you a little bit of a 2 slides on the vaccination, as Rebecca said, if you go one back. Obviously, vaccination equity is a big priority for this subgroup. I just wanted to give you a reminder. So these are total vaccinations in the over 50s, and it looks a really busy slide, so apologies. But I wanted to show you that when we quote what is the coverage or uptake of the vaccination, that we really need to be clear which denominator we use. Denominator meaning who do we count as eligible. And the upper bit of that slide shows you when we do the denominator from what we call NIMS, that is a GP information system. And then the lower one is when we use the population estimate for ONS. And the reality is probably somewhere in between, but you can see that in the latest time period for Merton, overall 79% of the over 50s have been vaccinated if you use NIMS, and if you use ONS, it's 94. So it's quite a difference. So I just wanted you to be aware so that you're alert and understand when information is presented, what is talked about. And then the last slide is just a reminder why we all can't go home yet. So vaccination equity, there are discrepancies in uptake, and not surprisingly, we've got an east-west split, because we know it's related big time to deprivation and ethnicity, etc. So we've got a focus clearly mapped out where we need to do more work. And I think you as a group have done really great efforts with super pop-up clinics, etc. in the East. So a big thank you, particularly to our primary care colleagues. So that's a canter through the main messages from the overview from me. Thank you.
Thank you, Dagmar. And I just wanted to ask whether Mark or Vasa wanted to provide an update on vaccine progress at all, just to add to the end of those slides.
Thank you, Rebecca. I think the main update for me is to say thank you for everybody who actually made that last slide possible, especially my people from Lower Morden there. Please note my Lower Morden end there. I'm really grateful for all my patients for actually turning up when invited, and also the pop-up team who actually pop up everywhere, all over the place, and they were popping up in Morden Mosque, I think, this weekend. Again, close to my patch, but I'm not biased in all this. This happens not because I do this, because Mohan and his gang and Barry and them decide where this happens. I have no conflict to declare there.
Thank you, Vasa. Did anyone have any questions to Dagmar on those slides, or any general questions? Ellie?
Yeah, just a quick one about the lateral flow tests and whether we're still pushing and encouraging people to do those. I suppose my specific question is, have they been useful so far in picking up cases locally, particularly in schools?
Yes, they have. So obviously there's always the question pain versus gain. But if you think the pain, one get used to it. It's a nuisance, but one can get used to it. For me, therefore, every single case we find who then can self-isolate is a winner. And I haven't got the slide with me. What we were looking at overall testing all the time, and we look at amongst the few positives we now have, touch wood, we had only 25 positives last week. What's the percentage that we pick up through lateral flow, and what is the percentage that we pick up through PCR? And as the infections are much lower, the percentage that we pick up through LFT is creeping up. Yeah, so possibly 1 in 3, 1 in 4, we are picking up with the LFT. So absolute numbers, not that great, but everyone counts. Stick it out if you can. Thank you.
Thanks, Dagmar. Vasa, and then Mohan.
Sorry, Rebecca. Mark sends his apologies. He's got computer issues, and I think he's fallen off the call. I think he's trusting Mohan and I will do the job for him.
Great, thanks, Vasa. Mohan?
Yeah, I just want to echo what Vasa was saying and what Dagmar was saying about the Merton effort. It's been absolutely fantastic, certainly with the Wilson and the Nelson being the hubs, and also the other pop-up sites, the mass sites as well, and the pharmacists also now coming on board. It's really been a massive group effort. And these pop-up clinics as well from common side to the mosque has really kind of had really shown good conversations and really bodes well for the future. So now that we're having conversations now we never had before in terms of what we can do sort of going forward about health coaching, about sort of health promotion, and it's really, really good to see. And I'll finish with the volunteers as well. There's 84 of them. And I had a webinar on Sunday just to sort of see how they're catching, just to check in, say, look, things are changing, etc., etc. 42 of them still turned up to find out what's going on, which I found was fantastic. And they've all pledged to support sort of well past COVID as well. So I think a massive resource, and Barry will speak to you about the community champions, how we can kind of link them in and certainly build on that as a pool to support, you know, all our work across Merton. Yeah, thank you.
That's great. Were there any other questions? I had just one question, Dagmar, just on the NIMS versus the ONS data, just to understand, is it that different data sets are being collected, or I suppose, is there any risk that some people are potentially missing out, or they risk getting missed if there's sort of a sense that actually you have a really high uptake, but it's possibly not as high as you thought? Just sort of a question purely looking at that slide.
Yeah, so I think it's a good question. If you would go back, I don't ask you to go back, but in my pack, because I'm conservative, as the overarching message that I'm giving at the moment, I do use the NIMS, just because I don't want to fall in the trap that I'm kidding myself. But I do also know that I don't do justice. To all intents and purposes, there might be some double, because what happens if you have a denominator in primary care, as you well know, particularly in London, there is a real shift of people in and out. So it is very likely that the denominator is slightly inflated, and if your denominator is inflated, then the uptake obviously appears lower than real. Yeah, but to be on the safe side, and also in order to use the data in primary care to actually really look who hasn't had the vaccine, you will see it on my last slide. We have given you numbers of what we think, how many people do we think are out there who haven't had the vaccine. In order to follow them up, to call them up, we work mostly with the primary care data set. Yeah, the ONS is more a sense checker, in that we do not do unjust under counting our effort. But so hopefully that gives you a sense that we're not deluding ourselves.
Great, thank you, Dagmar. Oh, Bassa.
Yeah, I think that point about self-delusion is the worst deception. And I think we should actually be erring on the side of caution and say we are at 80 rather than we are at 90, because I think sometimes if I tell my team we are at 90, then that extra bit of effort they give me every Friday night, I don't want to lose that. So I'll keep them on their toes by saying we are at 80.
Great, thank you, Vasa. Were there any final questions or comments on the COVID update? No, great. Okay, well then I think we'll move on to essentially sort of the bulk of the agenda, which is focusing on the insight work and building on that sort of communication and engagement work that we've done today. So I'll first hand over to Barry, who will share, I think, a presentation on the discussion of engagement and insight work, and then we'll move on to Hannah and to Andy, who will also present to us. Barry.
Thank you, Councillor. And I'm delighted to introduce this particular agenda item to the subgroup today. As we know, the subgroup have prioritised working with our residents, our community, and our thriving voluntary and community sector throughout the entire pandemic. And that's really to understand the impact of COVID on our communities across the borough, to prevent cases and outbreaks, but really also to increase the reach and the quality of our messages, and to build individual and community resilience. So the subgroup has had updates from these programmes previously, and really delighted to say that we've got 2 reports to discuss today, one from BAME Voice and one from Merton Mencap. The detailed reports are in the pack, in the agenda pack, so I'm sure many of you will have read those reports. So we've got 3 short presentations from the organisations, and the purpose of these reports is really twofold. The first to inform our immediate actions for outbreak control and immediate opportunities to build resilience within our communities, and secondly to shape strategic priorities and that longer term recovery work. So I will be quiet now, and I'm delighted to hand over to Hannah Neal from BAME Voice and her colleagues.
Hello. Perhaps we can have that first slide up. And just to say that I am merely the front for so many other people who have taken part in this work that we've carried out and who have also contributed very much to this report that we're presenting today. I'm afraid 10 minutes for a BAME person is really just not enough, but we'll do the best that we can. Now, how did we get to this point that we are now reporting to you on the resilience necessary for BAME communities in Merton? When we started hearing the frightening statistics about the impact which COVID had on our communities, we realized immediately that this would have serious implications for Merton because the health sector was already having concerns over certain serious illnesses which were affecting BAME communities, particularly east of the borough. So we immediately raised our concerns with some members of your board and others within the council and outside of it. And I must say that your reaction was swift. It was immediate and resulting in many consultations, one of them leading to the commissioning of our organization to carry out this piece of work. There is no doubt that your swift action and the actions of many have saved the lives of a lot of people in Merton. And for this, we're sincerely grateful. Can we have the next slide, please? Now, that piece of work was to design and deliver a genuine insight into the lived experience of people across BAME communities in Merton and the surrounding areas as a result of COVID-19, and also to look at the communities which had been most impacted by the virus, and that would be Bangladeshi, Pakistani, East, West, Southern Africa, Caribbean, including the Tamils and other minority ethnic communities. We started the work in August last year, and we finished it in February this year, 6 months exactly. And we spoke to approximately 300 people. 45% of them were young people, 180 were females, and 120 were males across all occupations. And the method of interview we used were varied, but we used also one very important one, which was our traditional one tells another, which we developed into pods, so that people who would normally meet together were able to do so and answer some of the questions they had put forward, and also some of the questions that we had suggested. So that you see there was phone and face interviews, there were online interviews, there was virtual resilient workshops, which were mainly with Merton Council workers who were very forthright in their feelings about what it was like working within the council. Can we have the second slide, please? So some of our findings, we found that there was no evidence that deaths and hospital admissions of BAME residents were disproportionate to their numbers within the borough. This had been the feeling worldwide and nationwide, that there was a disproportionate number of BAME people with the virus, and we didn't find this in Merton. And the projection that the Afro-Caribbean communities would be the ones that would have high levels of infection in the coming months, we didn't find this happening. It didn't happen at all. So we can say that when we approached this work, we were first of all sure that it needed to be done by BAME people themselves. It needed to be a BAME piece of work. And that was because we didn't want it to be an interpretation of what people said, but we wanted it to be what people actually meant, so that we used, the people we used for the interviewers, many were the young people that we had trained. They were the ones that went out and did the interviews. So they were from those communities, and they understood the communities, and the communities trusted them. So they were forthright in their views. And I have said before that there was a lot of thought and admiration for the way in which the council set about handling this issue. And a lot of people said that they were grateful for a lot of things that have happened in terms of the way that the council led the work that was done with COVID. And that is absolutely true. But also, I think we must say that historic issues of systemic racism as the overriding factor in the inequalities which BAME communities encounter, that was expressed by about 80 people of the people we spoke to. And there was also real anger that long identified and promised changes to the inequalities in East Merton had not materialized. But we did not want to go over old ground. That was not the purpose of this particular work. What we wanted to do was to get the feelings and the lived out experience of the people living in Merton. And this, we're very grateful to them, that they were forthright, they trusted us, and they spoke from the heart. And we're very grateful for that. But there was a lot of anger expressed, I think, because of this work that had been promised, that had not materialized. And I think to a large extent, quite a lot of this is due to perhaps a government lack of funding. But I think the communities felt that the council and the health sector could have done more in pushing these issues along. But with that anger, there was also hope. And I think people felt that the reality of life for BAME communities that had been shown so vividly and so graphically in what had been happening to people, they highlighted this, that they hoped that this would bring about the change. Today is the first anniversary of the George Floyd murder, and what people want to see is a change, as it's been echoed all around the country. No more talking, let's see some action. And so what we've done is we've got about 70 key recommendations in our report. Perhaps we can move on to the next slide. Obviously, there is not enough time to go through them, but the ones that were particularly mentioned was this whole issue about the popping up of health information centers, which I'm very happy to see is happening now, that these hubs are all over the place so that people can go and ask questions, and particularly people who can't speak English, so that these hubs would have people who would have information in the languages of these people. So also it was important that senior CCG and officers from the council met with these communities and not, just sending out information, but also going and meeting the people and speaking to them. And in education, it was felt that the school system needed to be updated, especially in terms of the work and the literature that was there within the schools. It's been said, there's an African saying which says, until the lions tell their story, tales of the hunt will always glorify the hunter. So there's a deep feelings about having Black history taught within the schools. In terms of employment, of course, the acceleration of minority ethnic workers into more senior leadership roles. This has been touched on so often. Also, in terms of employment, encouraging BAME entrepreneurship into East Merton, establishing businesses for small organizations, especially those that have grown up during the COVID, and more general a seat for BAME organizations at the decision-making tables, the authentic minority ethnic voices to be heard. And also, more importantly, perhaps finally, the stigmatizing of the communities and the marginalizing of the communities, but also the terminology that is used: hard to reach, seldom heard, high risk, vaccine hesitant. All these labels do not augur well for good community relations. And so I think I'll stop there. As I said, there are 70 recommendations that we have made, possibly over 70, but important to strengthen the social capital and view people from the position of strength. Most of the people we spoke to said that they didn't really want preferential treatment. All they were asking for was that a level field is provided for them. So provide a level playing field for the BAME communities would be a priority. So thank you very much for listening to this.
Thank you, Hannah, very much for presenting and distilling these insights. And as you say, the 70 recommendations that are in the report. And I think you've raised some really important questions and also challenges about what more work we need to do. And I think it'll be really important when we come to the sort of full discussion and debate, as it were, after agenda item 6, where we can really come to talk about those recommendations and how we take them forward as part of the LOMP and embed them in our work. So in terms of next, if we're okay to move on to Andy to present as well, and then sort of Barry to sum up, and then we'll come back as a group and we'll sort of take questions and comments and talk about how we can really embed these recommendations in, if that's okay with everyone.
Thank you. Thank you very much, Chair. Before I start, just a thank you to Dagmar for her very good report at the start of this meeting. These updates and in fact Merton's public health support for our work these last months has been absolutely critical to us, absolutely critical. We simply couldn't have achieved all we have without you, so thank you very much. Congratulations to Hannah and her team for her excellent research piece and very good presentation there and report. So I'm sure you are familiar with Merton Mencap, but in case we're a local independent charity which has supported children, young people and adults with a learning disability and autism in Merton for over 50 years. A learning disability is a lifelong disability affecting the way a person learns, communicates and understands. And as a learning disability is lifelong, family carers, it should be said, are lifelong carers too. Now, COVID pandemic has had a significant impact on our care group. A sobering statistic from Royal Mencap Society last month is that 8 in 10 deaths of people with a learning disability in England are COVID related. 8 in 10 deaths. So our work was to investigate the lived experience of people affected by learning disability and autism in this borough. And as Barry said at the top, provide recommendations to assist our thinking and strategic planning. So my colleague Paula Jewis carried out this research piece for us. I'm handing over to her now. Paula Jewis.
Hello, everybody. And thank you, Andy. Okay, can we have the first slide, please? Okay, so Andy's already told you what we were commissioned to do, but just to recap slightly, we went out to carers and also to the people they cared for, but also directly to people with a learning disability through other routes. So not necessarily just those who were the cared for of the carers we spoke to, but also other people with a learning disability, people who live in supported living, people who might live independently or semi-independently. We also spoke to parents of children and some children themselves as well. So what we were looking for was the opportunity to find out what their lived experience was, and how they reacted to and received the key public health messages. We also wanted to identify some practical responses, and in fact, we wanted to pick up immediate needs as well, so that we could intervene if there was an urgent need. And there were one or two which I can cover if people want to in the questions. We haven't got a slide on them, but we did do, I think, 5 or 6 particularly important urgent interventions, which we hope made a difference as we were going along. Some of which were connected with advice and guidance, and some of which were actually new services. So we also wanted to make sure we worked well with partners, so that we've got a broad reach, and understand any barriers to people accessing the support services that are there. And we actually found a lot of good support services out there, but we want to make sure that where people need to access those services, they do access them or can access them. And any barriers are, we look at how to improve the take-up. So those were our commissioning objectives. Quite easy, I'm sure you'll agree. Anyway, so we reached, I think if you add all that up, it's about 171 contacts in total, including the carers of adults, parents of children, people with a learning disability. And also we talked as well, which is a very important thing when we do engagement, I think, is we talk to the people who support our care groups on a day-to-day basis, because they have a particular angle to offer us. And we very much, when we do engagement work, like to double check everything. So, if a group of carers tell us one thing, we want to make sure that's borne out by what they're telling, for example, social workers, or what they're telling the people at their school. So we want to triangulate everything to make sure that our findings are sound, and they all match up. So hopefully that would be the case for all of the recommendations that you'll hear about today. So that's just an example of some of the organisations. In fact, today I realised I think we spoke to 14, not 10, so that slide is slightly wrong. Merton MenCap, as you've just heard, are the main supporters and providers for people with a learning disability in Merton, in the voluntary sector. So our staff as well have a particular focus in this area, and like the last speaker, we are embedded in that care group. We live it with them, and we are indeed, most of us, carers as well. So and then of course we look at reports, because there's a lot of work being done in COVID in particular, but also in another area we were looking at, which was digital exclusion, and there's some excellent reports out there. So we had to take those into account and use that in our triangulation process as well. Okay, next slide. So this is split into 2 halves. As it happens, we did a parallel piece of work for NHS England on digital exclusion amongst the carers in Merton, which are sort of tied in and wrapped into the piece of work we were doing for public health. So the first half of this slide is about the findings, and the second half focuses particularly in a bit more detail on digital, because that's another piece of work we sort of layer on top of this one. So what we found were that the priorities for carers during the COVID period were obviously the burden of caring, the lack of activity and respite for their cared for person. That's obviously the overwhelming change in everybody's life, is that their cared for person would normally go out and do activities, and they would get respite as a result, and that sort of initially almost disappeared, and then they did come back to some degree, sometimes virtual, sometimes part-time, but about a third of people received no services at all in terms of activities that they would normally do during the period. So overall, I think it was 75% of people, there it is, found that their burden of caring increased. the main priority for them were things like isolation and loneliness, which affects carers quite a lot anyway, but that was increased. And we found that some mental health issues lurking amongst carers and the careful people, which we'll come back to in a minute. Planning for the future and emergency planning is always at the forefront of carers' mind, but it's actually COVID has brought it even more to the forefront of people's mind, because the what happens when I die question is obviously made more significant by COVID. What happens if I go to hospital? What happens if my cared for person goes to hospital? And the immediate panic that a carer will feel when asking themselves that question, because we can't allow our cared for person to be isolated in hospital for fairly clear reasons. And so there's an immediate element of panic there. Access to health services, we found an issue particularly with regard to GP services during COVID. People felt unable to get the service they were hoping for from that group. They also wanted good vaccine information. We also would like to join with congratulating the local authority on some of the fantastic information they've provided, and also brilliant vaccine support. Reasonable adjustments have been better than we could have expected. We found the priorities for people with learning disabilities and autism themselves were: we miss our outings, we miss our activities, and we miss seeing our friends. Those were the big things. We also found that there was a sort of small group, but with very significant issues around anxiety, and we think had some significant indicators of poor mental health. Some of these people even started drinking more, they've taken more drugs, or even prescription medications have had to be increased. There were some examples we found of suicide, threats, self-harm, and also isolation of people with autism in their room, fearful of going out without a mask, fearful of leaving their bedroom without an enormous amount of planning and preparation. So we're seeing a number of small but significant risk group with regard to mental health. We found overall, though, the overall level of resilience has been amazing amongst our care group, but notably easier for people with digital access. Another thing is reduction in independence. About 2/3 of people who prior to COVID could have some level of independence, perhaps walk to the shops or even go on public transport independently. 2/3 of those people now, during COVID, were unable to leave the house alone for a variety of reasons, which are in the report. We found a number of things about schools, siblings, but overall, Merton schools have also stepped up to the mark and provided generally very good support. There was we found nothing significant to worry us about annual health checks and how many people take those up. Most people were keen to get their annual health check, but we found that virtual and phone health checks didn't work that well. And I've already mentioned that the NHS really overcame the vaccine hesitancy issue for us extremely well. And we expect that the uptake in our care group will have been quite good. And then on the digital side, I mean, we could go on about this for quite a long time, so I'll try and be brief. But first of all, our care group, we feel, are possibly the most excluded residents, or at risk of being so, because they fall into the 5 most high risk categories of reliant on benefits, tend to be female, tend to be older, etc. When we looked at people that responded to us or we engaged with, we found this was indeed the case, that 33% of them were basic or non-users, carers, versus 22% nationally. So they are a big excluded group, that is carers I'm talking about. We found that parents are not. So for the future, it's looking a lot rosier in this area, that parents, even of people with severe difficulties, are not really digitally excluded. It's this older carers that are the most digitally excluded. There are obviously lots of benefits if we could persuade these people to get online, but about 2/3 of the people who are basic users do not wish to be online. So it isn't the case that we can move all these people to being online. So we have to bear that in mind in any future plans with regard to digital. So we think the digital divide will widen because people are moving critical services online. With the people with learning disabilities themselves, we find quite a lot of the people that responded to us do have supported access or access to smart devices. But we found another group who are, if you like, excluded by proxy because their carers do not believe that it will be of benefit to them, or they feel they don't have the skills to be online. So we were very concerned about that, and we noted some people in supported living whose parents will not fund Wi-Fi for them. So the people in the supported living places or in the residential homes were not able to help them go online because they have no service. So we felt that was an issue that needs tackling. We also found a variety of reasons why people are not digital, so it makes moving people online a little bit more complicated than perhaps at first people might think. We have to look at each individual motivation and find personal hooks for everybody to motivate them. And we found a really poor awareness of assistive technology, which would be very useful for this group of people. So that perhaps needs tackling. And we also found that the professionals themselves are not confident to advise people about digital, even though they themselves are digital. So let's move to the next slide, as I'm aware I'm sort of getting into a bit of detail here. So the report recommendations really are matching those findings. So we think everyone who supports this care group should be working on sort of recovering those independent skills. We want mental health services to be slightly more specialist and accessible to our care group. We could talk about that in more detail at some other point. We will think some online services are fantastic and could continue, but we have to make sure there is not a two-tier system post-COVID, where those who are online get access to a service and those who are not online have a worse service. We need to think about giving carers the help that they're asking for around this planning and financial support and emergency planning. During COVID, if there's another wave, hopefully, but there won't be, but we need to think again about the ones who are socially isolated and digitally excluded, because those are the most vulnerable groups. We also need to think about disabled siblings going back into school because they've been affected. Carers and adults should be one of the priority groups for a digital inclusion strategy, which should be person-centred. I think I should finish there. I think hopefully you've read the report anyway, and are aware of some of these other things that we're recommending, like awareness of work and maintaining non-digital ways of communicating with our group as well. So thank you for listening, and we look forward to the questions.
Thank you, Paula. And again, thank you for distilling your report into those slides in that presentation. It sounds like sort of an exacerbation of existing concerns there as part of over COVID, but also some really interesting and complex findings around digital access in particular, which I think will be good for us to discuss after we pick up on next steps and launch opportunities. If I just hand over to Dagmar to present on that, and then we'll come back to questions for the group.
Yeah, so hi, I'm really in awe, and I won't take much of the time because I think we should get into the discussion. Great stuff that you've shared. It's quite humbling. I think what you've actually done was an intervention in itself, because you were out there with the people. Don't just think it's the report. It is also 6 months that you've actually done some fantastic work. So this is just very briefly a reflection what I hope we can move things on. So my sort of plea in a way for the council and the partners is that we manage this time round to allow these insights to shape proper strategic short, medium and long-term priorities. And the emphasis is on shape and the emphasis is on strategic. So we have a tendency to say, oh, you know, each priority, each recommendation will get a little project and then we've done it. I think this is a long-term engagement, and we need to be clear that it needs to properly be funded as co-production, ongoing dialogue, to be around the table rather than a one-off commissioned work. And I think that's a challenge for all of us. And I think you've articulated it very well. And I want that out in the open. And in terms of offers, I think we have to be crafty because the opportunities are there now for us to take hold of. The LOMP is there for a year. And so that is focused on the immediate, but it allows us to actually really get some prevention community dialogue, whatever it takes off the ground. And then I'm very keen that all our organization, but particularly the big public organizations, the council, the NHS, are all thinking around longer term strategic recovery. And this is the moment to face up with some of the structural inequalities, and having you and your insights ongoing around the table is what I think I hope we can commit to. I was really chuffed by the asset-focused approach, rather than listing all the things that are broken, to say is take us and our energy and our wit and work with us. And for me, that's a real call for us. And the last slide I won't dwell, but it's just showing you some hooks that are there for us to grasp. As I said, the LOMP is there. It comes with a bit of funding. We need to really turn it into value. The council is doing your Merton engagement at the moment. There's the refresh of the equality strategy, and there's a whole recovery and modernization program. That's where we want the insights to be really rooted and embedded. So I shut up, and I'm really looking forward to the discussion and all partners' comments. Thank you.
Thank you, Dagmar. And so I suppose if we do just kick off with inviting questions or comments, reflections on the voice of the community, as we heard from both Hannah and Andy, but then also how to follow up from Dagmar's point, how we can build on some of these insights in the short, medium and long term. So how we can take some of that action and learnings for the work that we're doing around COVID at the moment, but also build it into recovery. So I'll just open it out to the group to sort of questions, comments, reflections, and also how we can actually take some of this forward. If I go first to Everett, then to Mark, and then to Abby.
Oh, good evening, everyone. Just a massive thank you to the authors of both reports, which are excellent. And just to reassure everyone that in the drafting of the new equality strategy, the recommendations that are in those reports will be the sorts of things that we will be embedding into sort of our day-to-day business. And it's just been really insightful to know that the community have come to us with all these issues, and we're actually going to be learning and listening. And I think you were both right in terms of what you said, that, you know, there's a time for change. It's time for change. It's not just like a tick box exercise. And for me, refreshing the strategy, part of it for me is consulting with the community and already having recommendations that we can go back to you and check further to see what we could do differently, or how can we use those recommendations to just do things properly. And for me, it's embedding those considerations in our day-to-day business. So that's the key thing. I'm just giving you that assurance there in terms of doing that work. That's what my starting point will be. I'll still be talking and having the conversations with you, but certainly those reports for me are very insightful. So just again, thank you.
Mark?
Hello, I'm sorry I need to leave at 6 because I would have really looked forward to the conversation and hearing others. I think, first of all, thank you to Hannah and Paula. I think that was beautifully presented, but also a really important piece of work. Some of it not always easy reading for big services like the NHS or indeed the local authority, but really important. And it's just to back up Dagmar's statement there that we have an opportunity here to actually change the way that we work together. And I think whether it's under the auspices of the integrated care system or indeed the great partnership that we do through Merton Health and Care Together, there is a real opportunity for us to make sure that we are co-designing it with people, listening to our people. I know, Martin, I use your feedback to this group quite often, just in terms of our ability to listen. And I think that's really, really important. And I look forward to us being able to take this to the next step in a very co-produced way. And on that note, I'll leave, if that's okay, Councillor Lanning.
Thank you, Mark. Abby.
Thank you, Chair, and thank you both for the really interesting presentations. I did have a chance to read the reports, the executive summaries at least, and I think really useful to hear it from you both as well. I thought it was really interesting that you both talked about kind of young people in your kind of analysis. And I suppose my question really was for the BAME voices. You know, you talked about kind of having quite a good representation from young people in the study, and I just wondered if you kind of felt like there were any particular themes that came out from young people that maybe varied from the kind of rest of the group.
Yes, I think the main worry was about this division between the East and the West of Merton. And one of the people we spoke to, his concern was that he goes to school in the West, but he can't bring his friends to the East. But all their activities are carried out in Wimbledon area. And he feels that there's nothing here, East Merton, for him to bring his friends to. There are no cinemas, there's nothing at all. So there's a concern that this division will grow because there's not the equity in resources, equity in terms of what is available for young people. That's one issue. The other issue is the whole question about the educational system and the lack of any form of education about Black history. I'll give you a quote. One girl said, "My history was hidden from me at school. There was nothing taught to me that made me proud to be a young Black girl growing up in the UK." These were feelings that were expressed to us over and over again. So there are the many issues. The young people want somewhere that they can be proud of. And at the moment, they don't think that East Merton provides that for them.
Thank you both. Were there any, Ellie?
Thank you. I was going to make some of the point to Hannah about there were clear messages coming through from this for education. And I suppose a question back to you, Rebecca, and to others is to kind of what we do with these reports, because what's clearly coming, they were commissioned by Public Health, but these are not all public health issues that are coming through. This has to be owned by other people in council and other partners within Merton as well. So on the point like education, the team are working really hard with schools, trying to listen to their pupils and trying to address lots of the concerns that have been raised over the past year and before. So next month, we're having a big race equality and education conference with all of our schools. But I'm a bit worried if that's going on in a silo and then there's some work going on in here in public health on similar issues. How do we make sure that's all joined up?
I might hand that over to Dagmar just to pick up on, because I think, you know, in terms of one of our overarching themes around bridging the gap, that is a really sort of critical part of what we want to achieve as a council. I think collectively, I'll just hand over to Dagmar to just comment on that a bit further.
Yeah, so I think Ellie, a really well-made point, and for me to say we were almost just the vehicle to commission this report, but it is on behalf of the Health and Wellbeing Board, and the Health and Wellbeing Board is all of us partners. So public health is just a tiny little part, happens to sit in the council. So for me, that is so important. And we have got John Dimmer here as well, who clearly works for corporate policy as well, because I said, John, this can't possibly sit in a public health bubble. And while I've thrown in the lump because I feel fortunate in a way at the moment that I have a little bit of leeway and such good links into the community, that I think for short term, let's just be opportunistic, unashamedly opportunistic. But I've also said, and say it again, and it is on my slide, this needs to shape the council's and partners' strategic priorities. That means our whole recovery. It's not just a little project. It's not a one-off. I want these voices around the tables, not just once we've heard it, now we know it all. We need to bring them with us as we develop our priorities going forward. That's the challenge, and you're absolutely right. And I hand the package to us all. It's definitely not just public health.
Thank you, Dagmar. I think Vasa, then John wants to come in.
Thank you, Chair. Thank you, Paula and Hannah, for actually speaking the truth to us. We had to hear this version of the truth, because unless we hear it authentically as voiced by both of you, sometimes the message doesn't get through. But I think the message has really got through. It also made me reflect on a personal level. The Vasa you see at work is not the Vasa the pavement sees when I walk on the road. And I know exactly what you're talking about. When you cease to be a doctor, when you become a citizen, society sees you slightly differently at times. And I know it, and I say it from my position of comfort. So I can easily see others who are not as well established as I am in society will certainly feel things very differently. And I need to hear those authentic voices. It's a bit like if you had spoken to my mom and dad who first arrived in England in the 1960s, their feelings are different to mine. And I think I have reaped, I stand on their shoulders and I have reaped that capital which they have given me. And I think we need to be certain in our educational system that capital just transferred from them to me, enabling me to do what I do now. But my parents are both doctors, so I did have that economic advantage. We need to make sure in our educational system that people have that opportunity to prosper, that opportunity is available to all. And their health really comes in, because health is present in the East as well as it's present in the West. And we need to encourage children to aspire to these roles, which a lot of us from the minority communities actually perform in the NHS. I think, Mohan, we have a job here to provide people work experience, shadowing, following us, so that people actually can aspire that there is no glass ceiling in England. Nothing stops you and I, and nothing should stop anybody else. We need to provide that opportunity in our practices, in what we do, so that people can actually aspire, be role models in our community. And I think that's a big challenge for us to take forward. We need to share this report with all our practices. We need to read what people feel. No point me clapping for myself. We need to know what people feel about us, and then we need to respond to it. The journey has already begun. I don't want to say that we are now beginning. The journey has already begun. We look at the Diabetic Champion project, which Barry, Dagmar, you were involved in. We went out into the community to try and co-create an approach for diabetes. And I think we have to go faster and further in this. But having gone out into the community, pleading and begging people to get vaccinated, now we owe it to the community to go back to work on all the other stuff which we hadn't done before. And for that, we have to be honest and say, sorry, I didn't come before. But with that apology, I come now. And I think that should be the way we approach this. And I'm fortunate that Mohan, much younger than I am, is into TikTok and WhatsApping and all the other stuff which I don't do. I hope he connects more than I connect with the public in that particular way. We really have to, Mohan, work on this in our community engagement projects across the board. So with all our disadvantaged communities, with all our population, so that we can do what we can do. Of course, health can't change everything, but there's enough we could do to change outcome, and co-creation, co-production, and having the authentic voice, not the voice of people like me, the authentic voice in the room. So you can't tick a box by saying that Mohan is there and Vasa is there and the other Tamils are there. That just doesn't work. And I think we just have to remember that and work with Hannah, knock on her door as often as you wish, Mohan, to get people to join our work streams so that we can truly say that we have co-created with all our stakeholders. Because remember this, the minority ethnic communities of this country provide a significant number of people who work in the health service. So if we can't convince the community, then I fear for the NHS, because our significant proportion of our workforce comes from these communities. And if we get disentangled and start drifting, that is a disaster for the NHS. So really, it's in my self-interest to engage and ensure that the community feels involved and that the community continues to send their sons and daughters to work for this great institution, which obviously I'm totally conflicted. I depend on this for my living, but rest of the people depend on this for their life. So really, there is more than altruism here. Total self-interest comes to play as well. For the sake of the NHS, we got to make the community cohesion and engagement front and center of what we do. Mohan, do you want to say something, please?
I can do, but I think John Dimmer's before me. So
sorry, Chair, I took over your job.
That's all good. I mean, Mohan, do you want to follow on, and then John, and then Kaz? Is that okay?
Okay. Yeah. John?
No, it's fine with me, Mohan. You go.
Okay. All right. Yeah. I mean, yeah. Thank you both for the presentation. It was great, and I had a few comments sort of reflecting on that. And certainly, you know, the same thing around assets. That's massive, and I think we need to grow what we've got. We're all saying that. And what we don't want to do is bring new external resources in which aren't sustainable. I think the trust thing is massive, and I think we always sensed it prior to COVID, but we're really feeling it and hearing it and actually trying to change that now. And how can we do that? Even in a pandemic, that trust issue is still a barrier. So I look on how we can try and deliver that. It's not something overnight, and that's something which we will do or procreate with time as we go along. I did have a couple of questions though I did want to ask. Was actually on the work experience of getting students to come and see us. I think actually be flipping it around, and we actually go and see a day in the life of a young person and see what they experience. I did do a recent TikTok on the life of the day of a GP, just to sort of say what we do, because a lot of people think, you know, we don't do X, Y, and Z, but actually I think it's really useful for an educational piece to see, well, what are these inequalities which are seeing? I know they exist, and we've heard a whole array of them, but in terms of how we can see that in our own work streams, our own work life, it'll be useful, then we can start making that change. So my question is really around the health bit. So Hannah, around the sort of BME groups, in terms of where we think the health aspect is not being sort of targeted, or it's not being met, and how we might be able to change that going forward. What is it? And I know it's not just the medical sort of messaging, it's also the other bits, the well-being and the wellness, and how can we incorporate that in a better way?
I think the relationship, the doctor-patient relationship, is one that needs to be looked into, because one of the things that happened during this COVID situation was that I think there's been a lessening of trust between the GP practices and their patients, because a lot of people complained about difficulties with their GPs. I think also that I know that it's not really approved of anymore, the competency, the cultural competency courses and awareness courses that were run many years ago, which helped a lot of people. And I think that because our BAME communities, a good number of them don't speak the language, don't understand, and I don't think people realize how difficult it is for people who don't speak English, who don't understand the language, to communicate with their GP. Quite a lot of the criticisms we got on the ground was that the GPs just don't listen. And what people want is for people to listen, and you've quite rightly identified that you need to go to the people and not expect the people to come to you. So that step, if you took that step, even if it was just talking to assemblies, school assemblies, if they still have them, it would be a good thing. I think that's the best way for you to go out into the public and meet the people, and not be afraid to say, look, sorry, we haven't got it right. We've had a lot of good things. I think Merton, in terms of health provision, it's such an excellent, you can't beat Merton in terms of, but it's just the approach, I think, and it's the way in which people just don't know what's happening. The communication needs to be better so that people know that things are happening. It's perhaps not happening in the way that they can understand, but efforts are being made so that BAME people, by the way, people hate that term, BAME. I hope that Merton is looking at ways of finding other ways of identifying us. But that it's so necessary for people to know that they are valued, and they were more likely to take part in the confusion work if they think that they are valued.
Excellent, thank you. That's really helpful. And certainly as an East Merton GP, sort of reaching out into our communities, we're certainly doing quite a bit of that, but obviously more is needed. And also listening to what your requirements are, or what our requirements are. And I think one comment I often say is that we often forget that general practice is actually part of our community, and actually it's not seen as separate. And so we should be sort of working alongside that. Thanks.
Thank you, Mohan. John, finally.
Yeah, sorry about that. I had to go and deal with a dog that was barking, so that was quite good that Mohan intervened there. Just a couple of points from me. So firstly, I just wanted to say a big thank you and congratulations to both BME Voice and Merton MenCap on these two reports, which I think are excellent. And they're excellent because they're grounded in the lived experience. There's a very authentic voice kind of coming through there. I have to say, I really enjoy working with Hannah. I learn things all the time working with Hannah, and I learned something when we were doing this piece of work and kind of commissioning this piece of work in terms of what we should have been kind of commissioning. And someone made the point earlier as well that the piece of work itself was an intervention. So it wasn't just a kind of dry survey where you go out, find the results, and you get a set of recommendations. The way that Hannah designed it with us was that it was an intervention in its own right and made communities more resilient, and as a result of BME Voice's work, communities are more resilient. And I think that's a massively important lesson for me and for the wider group as well. I suppose just in terms of Dagmar's point around this kind of strategic framework longer term, I just wanted to highlight two pieces of work. So I'm working on Merton's recovery program. One of the projects in there is called Your Merton, and we are looking at our recovery program. We have at the moment our largest ever community engagement program going on. And that's covering a kind of 1,000 people sample survey. We've got an online platform going on, and we have got community groups who will be engaging on our behalf. And again, another lesson I've learned from Hannah is that if you want something that's of value to you, as in people's insights, that they give up their time to tell you something, that they want to make a difference, that insight is of value. And if you're using community groups to give you that insight, which you wouldn't be able to get any other way, then pay those groups to do that for you. And we're doing that. So Hannah, thanks again for that. So we've set aside a budget to do that. And again, that helps to grow community organisations as well. The importance of the Your Merton piece of work for me is that what will emerge, I'm hoping, is a collective ambition for the borough longer term, designed by residents, partners, councillors, staff, and that's a kind of something that we can all agree on as an ambition for the borough. but also a small number of strategic priorities. So rather than loads and loads of priorities, a small number of things which are really important to everybody that collectively we can achieve. And I think the big thing is that what I hope kind of will emerge with those priorities is things where collectively, if we all act together, we can make a difference to those areas. I'm pretty sure that structural inequalities, housing, our neighbourhoods is all going to emerge from that. And I think, again, the point's been made about how we then implement has got to be in a way that is working with communities, not doing to communities. And so they've got to be integral to the design of those solutions and the implementation of that. And that's going to mean a completely new way of working for the council, I think. And just the other project that I wanted to flag, which again, we're working closely with the voluntary sector and with the NHS. It's a bit of a mouthful, but it's called Transforming How We Work with Communities. We haven't come up with a very good acronym for it yet, but it goes back to a very fundamental point that the BME Voices report is making, in that if those communities don't have the kind of social infrastructure to support themselves, so community groups to support themselves, space to self-organize, then those communities are never going to be resilient, and they're going to be worse and worse impacted. The pandemic has demonstrated that they have been worse affected by the pandemic, and they will be slowest to recover. And those are our very deprived neighbourhoods and our very deprived kind of communities. And so investing in that social infrastructure is going to be critical. This is going to be longer term, because you're talking about system-wide kind of reconfiguration and moving money around as well. But I think you've got to start with that ambition. So those are two of the strategic areas, I think, where working together with our communities, we can make a big difference. Apologies for the dog. Okay.
Great, thank you, John. Kaz.
Thank you, Chair. I think that most of what I was going to say has been covered by previous speakers extraordinarily well, far better than I could have expressed it. I do want to reiterate my thanks to Hannah and to Andrew for their reports. It's brilliant work, and in particular, the methodology that Hannah had used is really an exemplar of the kinds of ways in which we can invest in our communities, and I hope will be an example of work that is commissioned going forward. One thing I suppose it's worth highlighting is, so when I have been working with communities, particularly, so yesterday, a conversation with the young men of African Caribbean heritage, what struck me was that there was a hope that things would be different this time, but a real sense of skepticism, because what the experiences that they were describing were in some cases very traumatic. And in that conversation, there seems to be a real distance between the people who were doing the research and doing the work, and the folks who were sharing their experience. So it was almost an intellectual exercise for folks who were observing. And I was struggling to close that gap. How can I make these intellects, these researchers, connect with these folks on a real human level? And the second thing that struck me in that conversation was the fragility of that hope. Because the fact that folks were coming to speak to them and really take what they were saying seriously was great. And at the same time, at that moment, I felt that what they were giving us was so precious that we had a responsibility to make sure that we really did come back. We were able to come back and say, this is our success. And I guess for this group conversation, I wonder in what way we are able to make sure that this is our risk, that the hopes and aspirations of these communities are something that we are seeing on our risk registers, that's something that we are seeing our collective responsibility to make sure we can come back and say, this is what you told us, this is what we've been able to do together and bring success in terms of the objectives that we formed with you.
And that's really important. I think this is a forum, as will sort of the Health and Wellbeing Board be, for us to continue to revisit this, because, you know, as sort of everyone I think has said, in terms of sort of short, medium and long term, this needs to be bedded into all of the work that we're doing as a system. And so this can't be just sort of a one-off discussion, but actually part of sort of the ongoing work that we're doing. Martin.
Hi everyone. Sorry that I missed the presentation, but I did have a read at some of the documents, and yeah, I wanted to just touch upon I think Bain Voice's report, because I thought it was great. I definitely agree with the young people interested in identity. I think that is one of the biggest I want to say like identity crisis that people have when they come of age. They don't really know what they should consider themselves, because they might look a certain way, but then they were born in a different place, and then they sometimes don't understand how to navigate that. And if your parents can't really teach you that, then it's difficult to navigate that and to find out by yourself sometimes. So I definitely second that. Anytime I've done engagement with that topic, people suddenly like engage. And when you get people to share where different people are from, then you find out so much more depth as to the individual. And it's definitely a really good topic to say. But there's that element, and there's the element of languages, which I think you've touched upon in the report. And you know, my first language is Spanish. My second language is English, and I also speak Italian. So I definitely think like culture is expressed through language. And if we're not able to listen to people in different languages, well, we're not listening to different cultures. And it's just as simple as that. And so I would say, you know, something that I push upon, and my view of London is that we should be more fluid with how we want to listen to people in different languages. And I'll give you an example. My mom doesn't speak English. So any type of GP appointment that I have to do, anytime there's a NHS, anytime there's anything like that, someone from my family has to go and translate. And so she is disconnected to some extent with the wider society because of that. And there isn't like a simple answer to that, but there is some kind of like, you know, if we really wanted to give something tangible to do, is like, how can we empower specific BAME communities that have specific issues and empower them to navigate the voluntary system and understand how to navigate grants and funding and stuff like that. Because really and truly, if there is a certain community that needs that, and I'm talking about a community that maybe the ethnic or the nationality of a community is here, then how can we get them to support them to start getting grants and funding so that they can have their own events and build their own culture within Merton? So that's something that I definitely take a lot of time to think about, because it's something that was a direct issue to me. So it's not like I can't not see that part. So I wanted to say that. And then the other thing I wanted to talk upon is about direct trauma and associated trauma, because there are things where like they have really happened to you, and then there is times when things haven't happened to you, but because you look a certain way, people are going to assume that that happens to you on a regular, or that you're about that life. And that's something that like I definitely think people sometimes have to have a real check about that, because not everybody has the same experience. And so, you know, I reiterated this point before when I said, you know, not all people who look a certain way think the same way or react to things the same way. Everybody's is different. And so, you know, just reiterating that we need to have individual conversations with people, and that individual conversation can take in any different language, and also about different things. So it's like, basically, I always think, you know, not to put people in groups and stuff. So, so yeah, I just wanted to touch upon those things. And I mean, because this is the council, I just think, you know, in terms of writing policy, because that's what we do and we enact, and, you know, policy, I just think we need to really be listening to people in different languages and really identify. So if there's anything from the report, I think just have a look at the communities. And I'll tell you one more thing, my ethnicity, I don't even have a tick box. So when I tick other, you're never gonna know what my ethnicity is. You see what I mean? So how many people within the ethnicity boxes don't have a tick box and are missed by the governance, right? How many people? Because I know my ethnicity, but you know, the council's never gonna see that. So how can we begin to get looking at the data properly and decide, okay, we need to maybe make it a little bit bigger, and we need to also let people define their own identity and how they want to be recognized as ethnicities. The other thing is, you know, there's so many, when we talk about Black people, for example, there's Afro-Caribbean, and then if you talk about African, there's so many different sides to Africa: North Africa, East Africa, South Africa, West Africa. So it's like, you know, we need to really be thinking about the diversity, right, that it takes to be able to really begin to talk about these things, right? And it's a complex issue. So just wanted to touch upon those things because, you know, they've been boiling my brain for a long time. So I hope, but yeah, thank you very much, Hannah, for your report. So cheers. Thank you.
Thank you, Martin. Brilliant. Some complex challenges at coming to the close of the meeting. I'm just going to hand it to Vasa and then to Dagmar. Oh, and also to Una.
Thank you, Chair. I think, Martin, what you said there is absolutely important. Culture is key to our behavior, and especially our health-seeking behavior, and the way we respond to health is. And also, you also point out not to go after labels, because my mother is Tamil, I'm Tamil, my daughter is Tamil. Three of us, three different generations. We respond to life in three different ways. My mother no longer responds; she's no longer with us. But she would have responded in three different ways. You would respond, and that is fundamental when we talk, especially about diabetes and blood pressure and stroke and weight and health and lifestyle. You wouldn't pay enough money to get my mom into a gym. You won't pay enough money to get me into a gym. My daughter will go to 3 gyms if you give her a chance in a week. And I think we just need to appreciate individuals and then learn how to work with them. And that's Mohan talks about personalized care. That's his new job title. And I think there is a lot for us to do, but we begin by being honest with each other. As I said at the beginning about vaccination, self-delusion is the greatest form, the worst form of deception. I think as long as we remember not to deceive each other and we speak truth to each other and we are willing to hear and listen and feel, then I think there is hope for us. And I'm very fortunate to have Mohan as my lieutenant. I call him many names. Lieutenant is one for the day, because he's the social prescribing, personalized care, community engagement, TikToking champion. He does all that very well. And I think we need to go on in that media to reach people who I can't reach. But the game's on and health is there. Hannah, I promise you, health is not running away. We are a bit embarrassed to hear the truth, but no harm in hearing embarrassing truths. That's how relationships are formed. And definitely we will come back in a year and judge what Mohan and I will do with community engagement in the next 12 months. Thanks to Barry, we have done a lot in the previous 12 months with vaccine engagement. We'll forget the vaccine story for a while and we'll do other engagement too. That's a promise, Hannah.
Thank you, Vasa. Dagmar and then Una.
Yeah, so very briefly, I just wanted to draw a bit of parallel and bring Andrew in as well, the really fantastic work that has been done with that community. And actually reiterating in a way, we're all individuals and the beauty is the diversity, and that's what we celebrate. And I feel we have rightly spent a lot of time around Hannah's report, but I want to say, you know, I've learned a lot as well from the resilience, the assets. I mean, I take my hat off anytime the carers and the spirit of the community you care for. And I think we have the possibility to really learn across and mix and jumble it all up and look at each of us as individuals. And that way, I think we have got a real opportunity to shift things this time round and hold us to account, Cass. And I think we have to somehow find a way that we hold each other to account, because when the running gets rough, and it will be, there need to be trade-offs, there's always the money issue. Somehow we have to think whether we have a yellow card system or something, that if we feel we're going off-piste, that we can remind ourselves to what we need to hold ourselves to account. It's just as a sort of a finish, that we're not letting go of it.
Thank you, Dagmar. Una.
Thank you. I just really wanted to reiterate the thanks to people for these reports, and I think it's really hit home all the different individuals that have made up those reports too. The presentations were superb, but the content of the reports is excellent. And yes, I think we have concentrated a lot on Hannah's report, and rightly so. And the individual, as I say, cases really shine through, and that for me is really important as a counsellor, ensuring that everybody has their voice and is listened to. And so, but I don't want to either miss some of the great work as well that was in Paula's report, and particularly some of the digital divide, I think, is actually pertinent probably across both in a sense. And that is so important, because nowadays, you know, particularly with COVID, that really has struck home the importance of digital. I know all of us possibly have struggled with it, you know, be it on Teams or Zoom or whatever. But to not have that huge access would, I think, be terrible. I know that just myself. So I really do feel we need to work as a council and partners to really help on that front, and where possible to get out to those people as soon as we can, and give them the support and help that everybody needs. So but as I say, for me, I thank you, and also I take home some other bits as well that are really important and shouldn't be. So some of the cultural divide, there's so much that can be helped through the arts, through sport, and through things which sometimes do get forgotten perhaps a little bit, as Dagmar just hinted at just now. You know, in all the rush to spend money where we think it's so important, we sometimes forget the importance of the arts, which in this time too have lost. And, you know, in bringing us back together again, I just think that's a really important side. So for me as well, and in education, I think sport and culture is so important. And yeah, where we can, bringing the East and West together, of course, has to be the priority. And that is where actually art and sport and so on can bring people together and create some greater good, and with health and well-being as well. So yeah, but thank you. And I think there is some really, really excellent work there. So I hope it can help us through good, yeah, and for long-term strategy as well, as Dagmar said. So thank you.
Thank you, Una. I know we're running on a bit, but I just wanted to bring in Hetty quickly to pick up on the comms plan that's going to sit alongside the vaccine equity plan. I know we've heard a lot of commitments on how we sort of address some of the recommendations and the challenges that have come out throughout the reports. I know that Vasa has put it to us to come back to him in 12 months to sort of monitor and assess, and I think we'll all hold ourselves to that challenge as well. But I just wanted to let Hetty come in on some of the work that's being done from the comms team.
Thank you. Yeah, well, it was really just to say that regarding the vaccine equity plan, we're putting a comms plan together to go with that. Which I was going to send a brief overview round to the group after this meeting, actually, because I know we're running over and we won't have time to go through it all and discuss it in detail tonight. The plan will just look at the main audiences that we and the CCG have identified. that we need to reach in Merton. It will look at some of the key messages we're suggesting for those groups, and it will also look at some of the tactics we can deploy in order to ensure that more people are taking the vaccine, basically. So there's quite a lot of stuff in there. It is just a draft, but if you are happy, I will send that round to the group tonight for your consideration, and then we will work it up into a full plan.
Thanks, Hattie. That would be great. So again, I know that we've run on a bit, but I think it was hugely valuable, a really interesting discussion, and some really key recommendations to take away there and to ensure that we're embedding as part of all of our work. So this won't be the last that we're discussing this, and it will come back to each of our meetings. But I just wanted to say thank you again to Hannah, to Paula, and to Andy for presenting those reports, but also for the huge amount of work that you've done over the last couple of months with the community to bring those insights to us. So I think I speak on behalf of the full group in sending our thanks to you. So thank you, everyone.